Dr. Washton. It's an absolute pleasure to have you with us today.
Yes, thank you, Daniel. Pleasure to be here. I look forward to this conversation.
So, Dr. Washton, your career has been nothing short of remarkable. So, to kick things off, could you share with us your perspective on different types of alcohol problems? It seems there's a wide spectrum, and understanding this could really help our listeners gain a deeper understanding.
Yeah, there's a tendency to paint alcohol problems with a very broad brush and to classify people as alcoholics or being capable of responsible drinking or social drinking, when in fact there are a large number of different categories of alcohol problems that are somewhere in between. It's actually a whole continuum, a whole spectrum of alcohol problems that people experience. In the past, we've divided them up into alcohol dependence or alcoholism, which is the most severe, alcohol abuse, which is problematic drinking that has not had devastating life consequences, and then responsible drinking, which is people who use alcohol for its pleasures and its benefits without experiencing serious consequences. And so when we talk about helping people with alcohol problems, we have to take into account the nature and the severity of the problem, because it's not a one-size-fits-all approach that will work for everybody.
That was really insightful. And it's helped me to understand a few things. Now, I'm curious about, like, I've heard a few different terms like moderate drinking and harm reduction, and I've read on your website a little bit about that. Can you kind of explain those concepts for us?
Well, harm reduction is a concept that's been emerging and gaining in popularity mostly within about the past 10 years. After it's been recognized, actually, for many decades, that insisting on complete and total abstinence as the one and only legitimate treatment goal for people with alcohol problems leads to pretty poor success rates. A lot of people don't come to treatment in the first place because they're turned off by the idea that treatment will pressure them to give up alcohol for life. Many people who start down the road of recovery and try to maintain abstinence find themselves falling back, at least periodically, and are left to feel like failures if abstinence is the only legitimate goal. And research shows that for people who attempt to deal with their drinking, reduce their drinking, or stop their drinking, the most likely outcome is reduced drinking to a level that does not cause serious problems, and total, complete, lifelong abstinence is the least common goal that people seem able to achieve. So harm reduction has taken on more and more meaning and gained more and more popularity, because it promotes the idea that any attempt to change one's drinking that reduces the harm and the potential risk of consuming alcohol are worthwhile steps that are taken and in the right direction. As long as somebody is working on their problem, showing some evidence of progress and reducing the harm associated with their drinking, then treatment is deemed as being successful. And we take the long view. We look at somebody going down the path of dealing with their alcohol problem in an incremental, stepwise fashion, where they reduce their alcohol consumption, sometimes significantly, sometimes little by little. So harm reduction is a strategy that has been shown in scientific studies to work. Many people prefer it as a treatment goal. It has helped to increase the numbers of people who are willing to come into treatment and give it a try, which is probably the most important benefit, because it's an approach that starts where the person is, rather than where you or others would expect them to be. And so people appearing for treatment that is delivered from a harm reduction mindset or perspective feel empowered, they feel accepted, they don't feel judged. And they're often better able to make use of what the treatment has to offer under those circumstances.
Would you say that the idea of total abstinence is really what sometimes just puts people off coming to treatment in the first place, because it doesn't seem as achievable as, let's say, moderate drinking and harm reduction?
Well, total abstinence, if it is promulgated as the one and only acceptable treatment goal, is a turnoff to a lot of people. A lot of people won't show up for treatment in the first place. And of those who do show up, some of them will drop out prematurely. Now, I think total abstinence is a legitimate and a good goal, and probably the preferred goal for many people who have serious alcohol problems. There's nothing wrong with total abstinence. It's how you get there that's the issue. And at least in my practice, when people come and they say they absolutely do not want to stop drinking permanently and for the rest of their lives, and they have serious alcohol problems that have caused them significant life-damaging consequences, what I usually say is, listen, let's start with just a trial period of abstinence for a short period of time, just so you can give yourself a break from alcohol, give your brain a rest from alcohol, achieve some distance from your drinking. If you decide at the end of, let's say, a 30-day trial period of abstinence, you want to go back to drinking, then we can put together some moderation strategies. But you'd be doing yourself a tremendous favor by at least taking a break at the beginning. For people who are unwilling to stop drinking, even for a short time, I will work with them on trying to make significant reductions in their drinking right off the bat. And usually the best way for a person to find out whether or not moderate drinking is a realistic goal for them is through a professionally guided attempt at moderation, where they're getting the benefit of professional guidance and feedback and education and support while they're attempting to reduce their drinking. And what I find is that when people make that honest attempt at moderation, and with all the support that they can muster, and they still find themselves unable to do it, they come to their own conclusion that abstinence is probably the better choice. I could have given them all the lectures that I'm capable of giving about abstinence and its benefits at the beginning of treatment. It won't substitute for somebody's own personal experience at giving moderation a try and seeing whether or not it works for them.
Are those all the strategies that we get that you use to help people to reduce their alcohol consumption or achieve abstinence? Are those the main strategies you use?
Well, there are different strategies for helping somebody to moderate their drinking, of course, and strategies to help them stop completely, even if stopping means on a temporary, not necessarily a permanent basis. So the moderation strategies are teaching people how to monitor their state of intoxication. That is, how the alcohol is affecting them. And certain guidelines will help to reduce the chances that they will drink beyond the point where they want to drink. So the goal is to stop drinking before you stop thinking. And that is what happens with a lot of people is that their well-intentioned goal to keep their drinking limited in a given occasion dissolves in alcohol as they continue to drink over the course of a day or an evening. And the goal is to stop short of drinking an amount of alcohol that disables your off switch. What people lack the most when they develop an alcohol problem is an off switch, a reliable off switch that tells them, okay, I've had enough. This is time to stop. So helping people set a particular goal in a particular occasion of, okay, I'm having no more than 2 to 3 drinks, but I'm going to consume these drinks over the course of 2 to 3 hours, not all in the first hour, because the rate of drinking is probably the most important factor that determines how hard the alcohol hits a person's brain. That is, if you push back 2 drinks within 15 minutes, it will have a much more profound effect on your state of consciousness, on your state of intoxication, than if you drank those same 2 drinks over the course of an hour or 2. You sipped it slowly. So teaching people how to pace themselves, intersperse non-alcoholic beverages in between their drinks. So, for example, the goal is over the course of a 4 or 5 hour evening of dinner or at a social occasion to have no more than 3 drinks. Intersperse it with water or some other type of beverage. Sip the drink, don't push it back quickly. Don't start drinking on an empty stomach. The goal is to slow down the rate at which the alcohol gets absorbed into the bloodstream so that it doesn't hit your brain harder or too hard, and you lose that ability to turn it off. Um, so the interspersing beverages, the not drinking on an empty stomach, also to avoid drinking carbonated alcoholic beverages like champagne, which intoxicates much more rapidly because the carbon dioxide bubbles in champagne speed the rate at which alcohol is absorbed into the bloodstream and brain. And you'll get much more intoxicated on a glass of champagne than you will on a glass of wine. And champagne is just carbonated wine. So sticking to wine or beer, drinking it slowly. It's also important for people to know what the definition of a drink is. When I see someone for the first time and say, okay, how many drinks do you typically have in a given evening? And they say, oh, 2 or 3. And I say, well, how are you pouring them? Well, I'm just pouring the vodka in a glass of ice cubes. Well, if you actually had a shot glass and you were measuring out how much vodka is in what you're calling one drink, how many do you think it would be? Oh, I've done that in the past. It's probably about 2 or 3. Okay. So what you're calling 2 drinks is probably 4 to 6 drinks. A drink unit in medical terms is any serving of an alcoholic beverage that contains somewhere around 12 or 13 grams of ethyl alcohol. And you will find that in a can of beer, a 5-ounce glass of wine, or a shot glass of distilled spirits. Those are all what's known as drink equivalents. They have the same amount of alcohol. So when somebody says, I only drink wine or I only drink beer, I don't drink hard liquor, that's really not the issue. Is how many drink units are they actually consuming per unit time, whether it's beer, wine, or liquor, because your brain doesn't care what flavor the alcohol was in when you put it in your stomach. It only responds to the level of alcohol in your bloodstream and in your brain. And so one has to do a realistic assessment of what their level of alcohol consumption is as the starting point for determining how much you're going to drink on a given occasion. It's also a very important factor in determining whether or not somebody is going to need medication to medically detox from alcohol without going into withdrawal. Because if somebody is consuming what they're calling 2 to 4 drinks a night, and it's actually 4 to 8 drinks a night, it may well be that they're physically dependent on alcohol, and it would be unsafe for them to stop it abruptly.
I'm wondering as well, like talking about, I guess, the different things that people can do in order to sort of get into a better place with their drinking. With addiction in general, obviously there's always like the concern of having relapse. Relapses, you can do the work, do the treatment, and sometimes you're still going to relapse. So what are your go-to sort of methodologies and support systems to help individuals prevent relapse, and how does that work? What does that look like?
In the treatment that I provide with my patients, I don't use the word relapse. I think it's a term that has a very negative connotation. It sort of suggests failure.
Right.
That you have to start back at square one. That's the way it's defined in the AA program, because if you've had 10 years of sobriety and you drink one day, you're considered to have relapsed, then your day count goes back to 1. I talk to my patients about a recurrence of drinking episodes, a return to a drinking episode, because a drinking episode by itself doesn't have to be anything close to what we would think of as a relapse. It can be an isolated incident. It can be short-lived. It can
The
be an
terminology is important there then, because
terminology is very important.
right.
It can be an episode of drinking that doesn't have particularly negative consequences, except the person feels so bad about themselves because they feel they've relapsed and they have failed. That's what I dislike about the term, and find from a clinical perspective, it's not particularly helpful. If somebody has a slip, if they have a short-lived return to a drinking episode, the most important thing to do is to help them not feel demoralized, to figure out how it came about. Are they aware of the thinking that led up to that event, or the circumstances that created the opportunity for this to happen? Is there something that can be done to prevent that from scenario from playing itself out yet again? Was it about being in the wrong place at the wrong time with the wrong people? Was it the fact that you were, in a bad mood or feeling depressed or down or angry about something and not sufficiently aware of your feelings and your desire to self-medicate by returning to drinking? Um, did you go to or were you in a social situation where you just sort of were dealing with drinking on the fly and no longer drinking mindfully, but drinking mindlessly? The ability to drink in moderation is very much dependent on being mindful about what you're drinking and not drinking mindlessly. Mindful, moderate drinking is really the only strategy that works if one's goal is to reduce their alcohol consumption rather than stop completely.
And do you find having this sort of approach with, clients that you work with allows them to feel more comfortable, I guess, to come and speak to you when they do have a recurrence versus making it feel like a failure and that, they're going back to square one? Does that change the way that, people, I guess, open up about having a recurrence?
Well, if you get rid of the word relapse and you start teaching people to think of their drinking and return to drinking as part of a process that they're involved in, and to focus on the positive, on the progress they're making, rather than the setbacks that they're experiencing, they're less likely to drop out. If they have a drinking episode, they're more likely to come in and report it openly and honestly and deal with it. They already feel shame and guilt about it, and there's no reason why a clinician, why a doctor, why anybody, any healthcare professional should stoke the fires of those feelings, because the person is already suffering from them without doing that. And what we need to do is to support them and help them move forward from it, not to wallow in the shame and guilt that they already feel.
Thank you, Dr. Washington. So it's interesting what you said that regarding people self-medicating themselves using alcohol. But in terms of medication, are there medications that could actually help people to reduce or stop alcohol drinking? And how would those medications work?
We have pretty limited options in terms of medications for treating alcohol problems. There are really only a couple of FDA-approved medications. One of them is naltrexone, which is actually an opioid blocker, and was found also to help people reduce their drinking. That is, it can reduce cravings for drinking. Once somebody starts drinking, some people find that it changes the way alcohol affects them, so they're less likely to want to continue drinking excessively at that point. I wish it was more effective than it actually is. My experience that medication works maybe in about a third of cases at best, sometimes only temporarily. I mean, it sounded like it was the cure for alcoholism at the beginning. Gee, if I could just take this medication and it can allow me to be a moderate drinker, that would be wonderful, right? I mean, I could retire if it were that easy, which I'm not intending to do anyway. But it's not so definitively effective. It can help some people some of the time. It's a safe medication, so it's worth trying. But I do give my patients a realistic perspective about, what to expect from it. Probably the most effective medication is called antabuse or disulfiram. Unfortunately, this medication got a bad reputation many years ago. It's been around since 1949 and has been grossly underutilized in the treatment of alcohol problems. It was the way it works is that if you take antabuse every morning, let's say when you get up and you have your morning coffee or tea, you swallow the antabuse pill, you feel nothing from it. It's like swallowing an aspirin, right? But you know that if you drink, you'll get sick. You'll get nauseous, you'll feel sweaty, you'll probably vomit, you'll just feel lousy. So people stop drinking and they stop thinking about drinking. It's amazing how the compulsion and the preoccupation for alcohol stops once people start taking the antabuse. It's not because antabuse changes their brain function. It's because knowing that drinking is not available to them because they're going to get sick if they drink, and the overwhelming majority of people don't test that. They take our word for it that it's going to happen. It is a very good medication for jump-starting the recovery process. If somebody wants to stop drinking and is not confident that they can resist temptation in the early phases, antabuse is extremely helpful in helping them get a start. And so I often suggest that people take it for the first 3 months if they want to be abstinent. It's not for people who want to moderate, for people who want to abstain, at least abstain at the beginning or at any point. It doesn't have to be taken every day. I have patients who take antabuse situationally. That is, if they know they're going to be in a situation where alcohol is going to flow freely, there'll be social pressures to drink, whether it's a business dinner or some special function or a social occasion with other people who are going to be drinking pretty heavily. Person can start taking the antabuse the day before the event, have the protection knowing that they can't drink because they're going to get sick, and then stop taking it afterwards. So it doesn't have to be taken every single day. Very useful medication and pretty much devoid of side effects. Very few people complain about any side effects from antabuse.
That's so interesting that I guess firstly that kind of medication exists, but also that it's underused because of the bad reputation when it could be so helpful.
It's grossly underutilized, partly because it got a very bad reputation in AA, because AA considered it a crutch, and that if you're on antabuse and that's what's helping you to stay sober, you're not really doing the work of the program. I think that's an unfortunate misconception, because this allows people to get a jump start that they wouldn't otherwise have. I should also mention that the medications that are used to treat depression and anxiety and how they figure in here as well, because a lot of people develop alcohol problems not entirely because they have anxiety and depression, but it does contribute. These can be powerful contributing factors. People are self-medicating for depression and anxiety. And that would lead you to think, well, if you give them an antidepressant instead of them drinking alcohol, won't that solve the problem? If we give them anti-anxiety medication, won't it reduce the likelihood that they're going to drink? The answer is, unfortunately, at the outset, the answer is no. Because by the time somebody comes for treatment or develops a problem, their drinking has gone on automatic pilot. The reasons that got the problem going in the first place may not be present any longer, may no longer be there. But the drinking has taken on a life of its own. There may be an underlying depression or an anxiety disorder. It's usually hard to tell until the person's been off alcohol for a few weeks, because alcohol itself, if you drink chronically or you drink heavily, it can cause depression and anxiety. That is, you can have an alcohol-induced depressive disorder, an alcohol-induced anxiety disorder, even an alcohol-induced bipolar disorder, for example, you can have. So you really don't know what the proper diagnosis is until the person's been given a break from alcohol for some period of time. But antidepressants and anti-anxiety medication for people who've suffered from these problems for many years, even before they ever developed a drinking problem, can be extremely helpful. They can help to reduce relapse because they remove at least some of the reason for returning to drinking. I wouldn't say that either of those types of medications are cures for alcohol problems by a long stretch.
Interesting that you mentioned that alcohol can induce bipolar. Are there other mental disorders that can be induced by alcohol?
The most common psychiatric symptoms that are induced by chronic or heavy drinking are anxiety, depression, and unstable mood. You see those very frequently in people who, when they first appear for treatment. It's very rare for me to see a patient for the first time coming to see me for an alcohol problem where they're not reporting that they have problems with anxiety, depression, or mood swings.
Dr. Washton, I was kind of wondering how much drinking is too much? When does drinking become a problem?
Well, the question of how much drinking is too much is an essential one to address. And unfortunately, we don't have a very clear, precise definition of what is moderate drinking. There have been attempts to define it. But at least uh, here in the US, the government has defined what is considered to be non-problematic drinking. They won't define any level of drinking as safe or, quote, moderate or healthy or acceptable, but they have specified what are considered the upper limits of what would be considered non-problematic drinking. And let me just take a moment to define how they arrived at that. They looked at actuarial statistics on the health effects of alcohol, and that is what level of alcohol consumption for people at various ages reliably leads to certain kinds of medical problems over time, as that person would drink chronically, right? So, like, how much alcohol, how many drinks a week would a person have to consume over the course of 5, 10 years or whatever for them to ultimately end up with liver problems, stomach problems, heart problems, kidney problems, other problems, right? Um, and what they came up with is that for an otherwise healthy adult man, having no more than somewhere between 2 to 4 drinks a day is the absolute upper limit of what's considered to be non-problematic drinking. Now, for some people, that's a lot of alcohol. And for other people, they seem able to handle that without an issue. So let's say if somebody comes home from work and they have 2 drinks every evening, a couple of glasses of wine over dinner, or a glass of wine over dinner, and a cocktail while sitting and watching a movie. We're talking about an adult male now, otherwise healthy adult male. That would be a total of 14 drinks a week. And according to the US government, that's the upper limit of what they refer to as non-problematic drinking. Now, you have to take into account a lot of factors here. This is assuming the person has no history of alcohol problems, has no medical conditions that would otherwise be aggravated by alcohol, is not taking medications that interact adversely with alcohol, right? Is not depressed or suffering from any other kind of psychiatric disorders, and whose life is reasonably stable. They're not involved in any particular crises, for example. That's a lot of ifs, a lot of conditions. But if we see somebody coming into treatment who's drinking multiples of that, setting that as an initial goal, as a target goal, for some people is a reasonable starting place. Anything above that limit, 14 drinks a week, spread out, as I just said, that doesn't mean a person can have 10 drinks one day and 4 drinks another day. It's no more than 3 or 4 drinks on any one occasion, right? With a total of 14 per week. And by the way, for women, it's the limit is half that, because women metabolize alcohol differently than men. We have a higher water content in our bodies, men do. And so women will get more intoxicated on less alcohol than will a man consuming the same amount of alcohol. So for women, it's 7 drinks a week. For men, it's 14 drinks a week. Anything above that puts you in the category that's defined as at-risk drinking, at risk of suffering medical or other kinds of problems related to drinking. I don't use those technical definitions with my patients. If they want to know what moderate drinking consists of, we have to talk about what that would consist of for them as an individual. Like, what level of alcohol consumption would be reasonable for you to be having on a regular basis, where it's not causing any problems in your life. That is, it's not altering your behavior in ways that other people, particularly your spouse or significant other, complain about. You're not intoxicated at a level where your driving performance would be impaired. You'd be a danger on the road. You're not drinking at a level that changes your personality in negative ways, that makes you irritable or hostile. It's not disrupting your sleep. It's not leading you to be socially withdrawn, not interacting with other people, with your children, with your spouse, not affecting your work performance. If you meet all of those criteria and you don't have any other medical conditions and not taking medication that would interact poorly with alcohol, well, what is your level of drinking? And for most people, it still falls in the 2 to 3 drinks on any given occasion range. Because what a lot of people find is that once they go past the 3 drinks, they lose their off switch. And if they have as many as 4 drinks, they're going to end up having possibly 6, 8, or 10 drinks. If they stay below that limit, the likelihood of flipping that switch, turning off their off switch, is much lower. So moderation is a term that has to be defined on a case-by-case individual basis. I don't think we can accept a blanket definition of it.
That's so interesting. I wonder if then it makes it harder for people to identify themselves whether they have a problem. Because if they look at somebody else, maybe they'll say, okay, well, this person drinks more than me and they're doing okay, it's not affecting their behavior, so I'm fine. Or the other way around, you could say I drink more than that person, but I'm not acting the way that they are. So maybe it makes it more difficult for people to accept, even though it's already difficult, even more so for them to accept help.
It's a good point because people vary so widely in their susceptibility to the effects of alcohol and how much a given amount of alcohol will affect their behavior and their personality. You could, I see patients, women in particular, especially women of lower body weight who are slender, who are older. After 3 glasses of wine, they are clearly, observably impaired from the alcohol. Whereas an average sized man drinking that amount, it would hardly be detectable. So it varies widely from person to person. It also depends on the person's level of tolerance to alcohol. If you drink regularly, you're going to be able to drink more alcohol with less effect because your body adapts to the presence of the alcohol. If you're somebody who happens to have 1 drink a week or 2 drinks a month, and on a given occasion, you're in a social situation, you have 3 or 4 drinks, you're going to get significantly intoxicated, especially if you have those 3 or 4 drinks in a reasonably short period of time because your body is not accustomed to processing that alcohol. So people vary widely in their response to alcohol. What may be a safe, non-problematic level of alcohol consumption for one person is quite the opposite for somebody else.
I wonder if then it makes it harder for people to identify themselves whether they have a problem. Because if they look at somebody else, maybe they'll say, okay, well, this person drinks more than me and they're doing okay, it's not affecting their behavior, so I'm fine. Or the other way around, you could say I drink more than that person, but I'm not acting the way that they are. So maybe it makes it more difficult for people to accept, even though it's already difficult, even more so for them to accept help.
It's a good point because people vary so widely in their susceptibility to the effects of alcohol and how much a given amount of alcohol will affect their behavior and their personality. You could, I see patients, women in particular, especially women of lower body weight who are slender, who are older. After 3 glasses of wine, they are clearly, observably impaired from the alcohol. Whereas an average sized man drinking that amount, it would hardly be detectable. So it varies widely from person to person. It also depends on the person's level of tolerance to alcohol. If you drink regularly, you're going to be able to drink more alcohol with less effect because your body adapts to the presence of the alcohol. If you're somebody who happens to have 1 drink a week or 2 drinks a month, and on a given occasion, you're in a social situation, you have 3 or 4 drinks, you're going to get significantly intoxicated, especially if you have those 3 or 4 drinks in a reasonably short period of time because your body is not accustomed to processing that alcohol. So people vary widely in their response to alcohol. What may be a safe, non-problematic level of alcohol consumption for one person is quite the opposite for somebody else.
I'd like to bring up as well, just because we were talking, I guess, about at the beginning of the conversation, we spoke a lot, I guess, about the physical things that one can do or the tools that they're given, I guess, to either be, completely alcohol free or to drink moderately. But I'm wondering in terms of sort of like the mental health aspect of it, obviously therapy comes in different formats. So how do you determine the most beneficial approach for someone struggling with alcohol problems? How do you know where to place someone, what the unique advantages of individual therapy versus group sessions are? How does that work?
At the outset of treatment, one of the most important parts of the process is coming up with a treatment plan that fits the needs of the individual person seeking help. And, the options typically include individual therapy, group therapy, medication, also encouraging people to get involved in self-help if they're open to that and that seems appropriate. Um, uh, Individual therapy is seeing somebody one-on-one is obviously the most essential way to get things started. When I see a new patient, I see them one-on-one. I will probably see them for at least 2 or 3 times individually, possibly have a joint session together with their significant other before formulating a more comprehensive treatment plan so that I can offer my recommendations based on having more information about the person, getting a sense of what they think would be right for them. And listen, the patient always has the final choice as to what kind of treatment they're willing to participate in. So the treatment plan is really based on what the patient wants, not just on what the clinician thinks might be best. So it's a kind of negotiation and a discussion with somebody as to, here are the options, here are the menu of options. Which of these do you think would work best for you? After explaining to them, of course, what's involved. In my view, group therapy is probably the most powerful treatment option. Not everybody is willing to be involved in group therapy. Not everybody is appropriate for it, and I'll get to that in a moment. But small groups of like-minded people that meet once or twice a week, which is the way that I do the group treatment, is a very powerful way for people at the beginning of the process to get information from other people who are traveling the same road, to be able to identify with them. It does a great deal to assuage shame and guilt because they see that other well-functioning, intelligent people are dealing with the same problem. The peer support and the feedback that people get in small group therapy, there's really no substitute for it. So ideally, if somebody is willing to be involved in a small support group that meets once or twice a week, doesn't interfere with their work and their other responsibilities, that's ideal. In combination with, ideally, with individual therapy. Group and individual therapy are not good substitutes for one another. They really address different things. In individual therapy, there are things that people will talk about and will want to talk about that they don't feel comfortable talking about in a group setting, and that's understandable. Also, sometimes things come up in a group that really need to be looked at more intensively, and we really need to drill down on some issues that may arise in a group discussion. And so in a subsequent one-on-one session or series of one-on-one sessions, we have an opportunity to zero in on those issues. So for me, the ideal plan is a combination of group and individual therapy, where I have the opportunity to see somebody one-on-one. I also see them in a group context. They can benefit from the peer support and the information sharing that they get in the group, and they can benefit from us zeroing in on some of the personal issues that are connected with their substance use. In my view, substance use problems, whether it's alcohol or other drugs, are self-medication problems where people have used alcohol and drugs as ways to manage their feelings and their mood states in ways that were not accomplishable by other means. And they need to learn better coping skills, ways of dealing with emotional problems, how to identify emotions, how to manage their emotions, how to cope with stress and anxiety, how to deal with their most important relationships in their life and the conflicts in those relationships, whether it's conflicts with coworkers, supervisors, bosses, spouses, children, parents, whomever. So ideally, being able to work on those things in both group and individual therapy is what appears to work best. Medication, when needed, certainly can be part of the picture, regardless of what the therapy happens to be at a given time.
Thank you so much, just in general, for sitting down with us and having this conversation. I think that for people and our listeners specifically to hear this information and to know that A, help is available, and B, there are so many different layers, I guess, to being dependent on alcohol, and it's not just one thing, and it's not just one approach. People have to try different things. I think it's just really valuable, and I'm so glad that we get to hear your extensive knowledge on the topic and to really sort of bring it to other people to listen. And thank you so much.
Thanks for the opportunity. Really appreciate it.